And there are actually groups working on that hypothesis in the lab, but I will not go into details because there's not enough time. Now, as the last part of my talk, I would like to discuss whether all the expected benefits of iron chelation therapy in MDS actually translate into improved overall survival. And the first indication of that was given by a small retrospective trial in Canada, which showed an impressive impact of iron chelation therapy on overall survival in lower-risk MDS patients. But this was a very small retrospective trial, which, however, was later supported by a much larger study from France, which was a partly retrospective and partly prospective trial. And again, there was a significant impact on overall survival if patients with low-risk MDS or patients with intermediate-risk MDS received iron chelation therapy. And in our institution in Düsseldorf, we performed a matched pair analysis, looking at 93 pairs of MDS patients who were either receiving chelation therapy or not receiving chelation therapy. And these pairs were matched according to age, sex, and WPSS risk score. And we confirmed, again, a favorable effect on iron chelation therapy, on survival, but not on leukemic transformation. Now, so there is accumulating evidence that iron chelation therapy is indeed able to increase the likelihood of survival. But we have to be aware that iron chelation therapy can also cause adverse effects. What if iron chelation therapy is too toxic? Well, you are probably not aware of the limitations of deferoxamine therapy, because I learned that this drug is not licensed in Mexico. But in other countries like Italy, there are more than 3 decades of experience with this drug in iron-overloaded thalassemia patients. And I can tell you that for doctors and patients, it is a real hassle, because it's a drug that has to be given parenterally. It has a very short half-life. There are huge problems with patient compliance, and there are problems with injection site reactions and pain, and the administration is very inconvenient. So everybody was looking for an oral iron chelator. And the first oral iron chelator that was on the market was deferiprone. But deferiprone is also not without side effects. Deferiprone is an oral iron chelator that can cause agranulocytosis. And the agranulocytosis frequency is different in different clinical trials and reviews, but it's usually around 1 per 100 patient years. But it can be very dangerous if you do not monitor the white blood count in these patients every week, or at least every second week. Then you can be caught by surprise with a patient who comes back in sepsis because he's got no granulocytes. So the latest oral iron chelator is deferoxamine, which has a long half-life, which can be given orally, which makes treatment very convenient. But this treatment was also not completely without side effects. Deferoxamine does have a certain rate of gastrointestinal disturbances, mainly diarrhea. And in the clinical trials, a sizable proportion of the patients stop the treatment because of diarrhea, and elderly patients have more diarrhea than younger thalassemia patients. And now a clinical trial is being started looking at the possibility or trying to support the anecdotal evidence that the drug is much better tolerated as far as diarrhea is concerned if it's taken in the evening. We'll see. And in contrast to the gastrointestinal disturbances, hepatic toxicity is clinically not a significant problem. Indeed, when iron chelation therapy is successful in bringing down the serum ferritin levels, it is usually also capable of decreasing the transaminase levels, indicating that with removing iron from the liver, you will have less toxicity from iron overload in the liver. So all in all, the effect on the liver is favorable. And a lot of discussion has focused on renal toxicities, and most patients, most elderly patients treated with deferasirox experience a decline in their glomerular filtration rate. And this is shown on the left part of the slide because the glomerular filtration rate during treatment is lower than baseline. Most of these dots are below the diagonal. But the blue dots show patients where no renal dysfunction adverse events were reported according to clinical trial protocols. The patients where renal dysfunction was reported as an adverse event, as a renal dysfunction adverse events, are those red dots or red triangles. And when we zoom into this graph, we can see that the proportion of red triangles is much higher in those patients who were started on deferasirox treatment with a creatinine clearance lower than 40. So it's probably not a good idea to start a patient with such a low creatinine clearance on iron chelation therapy with deferasirox. And this is also an important graph showing that patients with MDS with a baseline creatinine clearance below 60 did not have a greater decline in renal function over the course of the study than those with a baseline creatinine clearance of above 60. So 60 is probably not a critical threshold. 40 seems to be a more critical threshold. And the label in the US now says that patients with a creatinine clearance between 40 and 60 are allowed to be started on the oral iron chelator. So all in all, I think that there's a favorable risk-benefit ratio in favor of iron chelation therapy. But this does not mean that we can do without a properly designed prospective clinical trial, such as this trial, the Telesto trial. And this trial is a prospective multi-center study to investigate the clinical benefit of chelation therapy with deferasirox in 630 MDS patients. And the primary study endpoint is event-free survival with a special emphasis on cardiac and hepatic non-fatal events. And patients are randomized to receive deferasirox or placebo in a 2-to-1 ratio. And I can tell you that it is very difficult to recruit patients for this trial in countries where deferasirox is licensed and reimbursed. Many doctors are not inclined to put their patients on a randomized trial where they have a 1/3 chance of not getting the oral iron chelator. So it's very difficult. Recruitment in this very, very important clinical trial is miserable, unfortunately. But I think we desperately need data from this clinical trial to prove what most hematologists believe, namely that transfusion-dependent patients with lower risk MDS benefit from iron chelation therapy. And finally, I must say that about 10 years ago, the topic of iron chelation and iron overload in MDS was actually much less of a topic than it is now. And this heightened awareness has been linked to the availability and also to the promotion of the oral iron chelator deferasirox. But I think the real question is whether this current interest in this topic is exaggerated or whether a veritable clinical problem has previously been neglected simply because it was so cumbersome to treat. And on that note, I'd like to close and thank you for your attention.